Welcome to the Alphabet Soup of Chest X-Ray. I'm your host of this Geeking Out Pre-Hospital Physician episode, Dr. Daniel Shireen. When we're looking at chest X-rays or any radiographs in general, we have to make sure that we have the right patient, the correct film, ensuring that we have the right date and time of that film. We have to look at the left and right aspect of it, and then like anything else that I talk about, you need to make sure you know your anatomy. First and foremost, though, let's talk about God's rules. God likes symmetry. If you think about it, left and right, our left hand, our right hand are the same thing on the chest X-rays is pretty much symmetrical from that perspective. God hates straight lines. There's really only one straight line in the body, and that's the gastric bubble, when we'll look at that later, that you might have an air fluid level there. And of course, God loves old X-rays. Pertaining to the chest X-ray, the majority of the time, this is going to be a single-shot anterior-posterior view, meaning that the beam is coming from the front and the plate is actually behind. So the heart shadow actually could be a little bit bigger in size compared to if you do a PA. Breathing chest X-ray, different perspectives in regards to the trauma setting versus the pneumonia. There's really not much. My mantra, kind of sort of how I teach this, is the ABCs, and then we talk about the RIP. In regards to chest X-ray and the anatomy, okay, you have to know the different pieces. So you have the clavicles at the top, you have the trachea coming down, the carina, or the bifurcation of the bronchioles. From there, you got your right atrium and the left ventricle, the right hemidiaphragm, the left hemidiaphragm. You have a whole bunch of ribs. The scapula, you can see the head of the humerus, and then even some of the spinous process. So let's take a little bit extra dive here. Okay. First of all, got the trachea down the middle. From that standpoint, different bones. You got the head of the humerus, you got the scapula, again, of course, the ribs and all that stuff. Aortic knob, that's a little piece of the top of the heart where the Azygos vein and all that stuff comes through. The carina, or the bifurcation of your trachea into your left and right main stem. The lung fields. The left ventricle, the right atrium. Then of course we can see the SVC. And like every good trauma patient, you're going to have a backboard there. How do we know if the chest X-ray is actually good X-ray? Well, we use the RIP method. So the rotation, inspiration, penetration. When you're looking at the X-ray, you should be able to see both of the clavicle heads. They should be pointing straight out at you. On the inspiration side of it, count down to 10 ribs. If you can't see 10 ribs, it's not they didn't take a good breath hold and all that stuff. And the penetration side of it is if you look at the chest X-ray, you can actually see the spinous process and the vertebral bodies. So how do we do our ABCs? Well, the first one is our airway, like everything else. Is the trachea midline? Do you see the bronchi? Our bones, do you see any fractures, lesions? You should be able to count your ribs from that aspect. The humerus, the humerus. Look at your clavicles, the scapula, and then you can even see some of the going up higher into the cricotillage or the trachea and all that stuff. Cardiac silhouette, don't forget about the mediastinum. Our diaphragm, looking at the left and the right, is elevated as a flat. Edges. Everything else, look outside the chest X-ray. So often you can actually see subacute air, you can see foreign bodies, look down into the corners, the fissures and all that stuff. Our fields, okay? Do you see any increased vascularity, masses, your air bronchograms, okay? That's the fields are the lungs. Gastric bubble, like I said, the only thing that God likes as a straight line is inside the gastric bubble. The location, is it above the diaphragm? Is it below the diaphragm? And then the hilum, okay, or the lymphadenopathy, you can actually see viral, or what they call viral cuffing from that aspect for pediatric patients, adult patients. And the final piece of it is the instrumentation. Is there an endotracheal tube? Is there an NG tube? Do you have a chest tube? So anything from that standpoint. So let's actually look and dive in each one of these pieces here. Okay, so in the airway, from that aspect, do you see, okay, coming down in the piece of it at the crown and all that stuff? From there, the bones, you have your ribs, okay? You should be able to count at least 10, down to 10 ribs. You have your clavicles, head of the humerus. From there, even the spinous process is coming down to the vertebral bodies. And like I said about earlier about the penetration side of it, is you should barely see the spinous processes. Cardiac silhouette, the heart size from that standpoint, and we'll talk about this a little bit. The heart itself should be no more than half the size of the actual chest cavity and all that. Our diaphragm, okay, is the left higher than the right? Do you actually see the gastric bubble or context coming above the diaphragm? Edges. Don't forget about the edges. Go all the way down into the bottom little fields and all that stuff. Edges there. And then everything else. Look outside. Do you see air? Is there something that you're missing? Fields. Okay? Have to look at the lung field. Are they symmetrical? Is one collapsed down? Do you have any problems from that standpoint? Gastric bubble, like I said, okay, this one doesn't really have a good air fluid level, but you can kind of sort of make out from that perspective. But is the gastric bubble itself above the diaphragm? And so if it's above the diaphragm, we know that's not a good thing. It means that we're the potential of looking at a ruptured diaphragm. Hilar regions. Okay, what we talk about with kids and all that stuff is the bronchial cuffing or just the air bronchograms and all that stuff. You can see lymphadenopathy from there. And then anything else on the instrumentation wise, chest tubes and all this stuff are pretty obvious. For pediatric patients, not much difference. Same piece, same process. But again, what I talked about earlier is the chest X-ray good? For on this one, you can actually see, are the clavicles and all that stuff, are they straight out at you? Okay, so this one is actually rotated a little bit. That's why the kid's heart and all that stuff looks like it's going over, it's on the right side. The other piece of it for pediatrics too, they still have a big thymus. Okay, so this organ and all that stuff helps out with the white blood cells, but the thymus is still present, so what looks like it might be a mass, but that's actually normal for kids. So let's talk, we're going to go through pieces, some cases and all that stuff, kind of sort of let you look at it for the first few seconds, and then we'll go further. Okay. For this one, pretty much straight up, unfortunately, too low. Okay, we can get down into we'll see a lot into the abdomen, but we're missing everything up higher. We have to be able to see the chin, kind of sort of, that's our hallmark, the heads of the humeruses and go from there. Pneumothorax, pretty obvious. That's that edge piece that I keep talking about. That's what you're looking for. Yep. This is where you get into the hemothorax. You see all that white. Okay, on a chest X-ray, okay, if the patient is laying flat, that's going to diffuse out. Might be a little bit hard in the aspect of if they're sitting upright to tell the difference between an effusion versus a hemothorax. Of course, take everything into consideration. Is this a trauma? Something from that standpoint. All right. The effusions. Okay. Does God like straight lines? No, God does not like straight lines unless it's in the gastric bubble area. And these are two different aspects. You got a effusion on the left for over here, and you got a effusion on the right over there. Does not like it. Mediastinum. Okay. The traditional teaching of that is greater than 8 centimeters, and that's on a PA. But if it just looks wide from that standpoint, you have this nice wide medium sinum, there's something bad going on there. Look at that heart, okay? Big heart, cardiomegaly. As I said earlier, the heart should be no more than half the size of the thoracic cavity. So in this one, you can actually see these two lines are the exact same sizes. From that standpoint, the heart itself would actually go outside the cavity and it still reaches to the right-hand side. Fluffiness. Okay, anything from that standpoint, pulmonary edema, ARDS, CHF, drowning, toxic exposures, all that stuff will cause this fluffy pattern. Different cases of pneumonia from the aspect on the left picture. Okay, this is a right inferior lobe pneumonia. Okay. Versus on this other patient on the right-hand side, this pediatric, where you see this kind of sort of into the middle lobe, which is kind of sort of classic for them, especially with how their mainstem, right mainstem bronchus just goes straight down. A lot of times for the pediatric patients, they'll get pneumonias into that corner next to the cardiac silhouette and all that stuff in the inferior lobe. Never a good sign. Trace through, right there you can see the diaphragm coming through, and then that little space underneath of it, okay? So you have a little bit of space between the diaphragm and the liver. That's the air, okay, from that perspective. Perforated bowel. Like I said earlier, again, gastric bubble, okay? Straight line, only place where God likes that. Flail chest, when you're looking at ribs and all that stuff, multiple rib fractures, okay? Chest tube, of course, in places from that standpoint, but you can see the different rib fractures and all that stuff. 4 ribs, flail segment, bad problems. Chest tube goes up and around and gets kinked right there. That's an issue. Definitely not inside the chest like it's supposed to be. For this one, okay, someone actually tried to needle decompress the patient. Fortunately, didn't need the needle decompressions, because if you actually go and look at the lung fields, the lung goes all the way up, all the way around. Okay, the needle right there and right there. Okay, that from that standpoint didn't even reach the chest wall or the chest cavity. Okay, ET tube pushed down past the carina, going into the right main stem. Pediatric patient. Okay. This is your steeple sign. When we think about Coop and Strider type pictures, you get that nice push up and all that stuff for the steeples. Our last part of the slideshow, just to kind of sort of throw something different, dextrocardia, basically the heart, or you'll have situs inversa, where all the organs are flipped left and right for dextrocardia. The heart is on the right-hand side versus the left. And you can tell, I mean, on the chest X-ray, they documented it as a left. Different perspectives, just for food for thought from that standpoint. Biggest thing, like everything else, make sure that you just keep looking at X-rays over and over again. Go through systematic process. I teach, now I love using the ABC method. Make sure that your X-ray is good with regards to your RIP process, and then enjoy. If you like this video, please subscribe to the YouTube channel Pre-Hospital Physician.